I'd like to welcome all of you to today's Physician Mentor Program featuring Dr. LEIF ROGERS. I'd like to take a minute and leave the disclaimers up. Please read briefly through these. Now I'd like to introduce today's guest speaker and provider. Dr. LEIF ROGERS completed his medical degree at Columbia University, residency in general surgery at New York Presbyterian Hospital, and fellowship in tissue engineering at Columbia and Carnegie Mellon, followed by training in plastic and reconstructive surgery at the University of Pittsburgh and a cosmetic fellowship at Lenox Hill and Manhattan Ear, Eye, and Throat Hospitals. He has received grants from Columbia University, Plastic Surgery Education Fund, and the National Institutes of Health. Dr. ROGERS is certified in plastic and reconstructive surgery by the American Board of Plastic Surgery, is on staff at Cedars-Sinai Medical Center in Los Angeles, California, and Providence St. Joseph Medical Center in Burbank, California, and performs advanced trauma reconstructions with the Cancer Center at Huntington Memorial Hospital in Pasadena, California. He is a member of the American Society of Plastic Surgery and a fellow of the American College of Surgeons. He is affiliated with multiple charitable organizations, including Iraqi Star and Helps International. Today's agenda looks like this. We're going to have a presentation by Dr. ROGERS where he'll talk about the mechanism of action, and then he will review some of his before and after cases. Then we will transition down into the operating room where you'll see a live case. And during that time, we're going to encourage you to ask all of the questions that you have for Dr. ROGERS. You'll see at the bottom of your screen on the right-hand side, the icon for Q&A. Please present all of your questions right here, and we will make sure that Dr. ROGERS has an opportunity to answer those during this event. So please join me in welcoming Dr. LEIF ROGERS.
Good morning, everybody, or maybe not morning, depending where you're watching from. So we're going to talk about Renuvion today, its indications for use and risks. So we'll go also into all the science behind it to a superficial degree, just so at least you understand what it is that we're actually treating our patients with. So the Renuvion system is indicated for the delivery of helium plasma to cut, coagulate, and ablate soft tissue. Renuvion has received a general clearance. It's as noted above. It is not cleared for anything specifically, but it is cleared for essentially all things that include coagulation and ablation of soft tissue. Of course, there are some inherent risks with energy devices, and that's something that we will talk about and something you can look up on the website and various other information that the company can supply you with. So what is Renuvion? It's a cosmetic technology. The way we're using it is a cosmetic technology combined with unique properties of helium plasma and proprietary RF energy. It's used for cutting, coagulation, and ablation of soft tissues and dissection to some degree, but really it's the first three. Actually, it's the middle two. Coagulation, ablation are the most, or what we're using it for. Again, what is plasma? So the various different phases of matter, you have solid, liquid, gas, and then plasma. So one goes to the next. Plasma is ionized gas, essentially. So you see those plasma balls where you put your hand on, just like in that picture, that is plasma. We're doing the same thing, but it's much higher energy, so we can cause essentially a heat injury to whatever it's arcing to. So how do you create plasma? You essentially energize it. Oh, how do you play this? There's a way to play it, isn't there? Even if it doesn't play, don't worry about it. Bottom line is, electrons can charge the gas, which is the helium. The helium comes out at the tip of the handpiece, and the electrons can arc across the gas molecules, and the electron basically gets kicked off of the helium, and then it'll go towards whatever is the most conductive. In our case, it's collagen. This is the quick history of the device. So Bovi, the company Bovi that we all know that makes electrocautery and has for many, many years, found a J plasma, which is its original name, in Germany back in 1998. They got a 510K approval in the US in 2012. They started focusing on GYN type of procedures like endometriosis and laparoscopic type of procedures. Dr. Delosier independently did his first dermal resurfacing case. That's something that we're not going to talk about today, but that is on the list of things you can do with it. That was in 2013. 2014 to 17, the company expanded more to oncological type of procedures. In 2016, Dr. Zamora did the first subdermal case, and he did it in the neck. In 2017, the cool coag was introduced. This is the subdermal market. So the company expanded it to cosmetic type of procedures. In 2018, the company relaunched the product as Renuvion, changed the name from J plasma to Renuvion. And then in 2019, the company changed its name entirely from Bovi to Apex. This is a little bit of data that validates what is actually happening when we treat tissues. So here it shows the various energy settings between 60 and 80%. They did a wider range of settings, but these are the effective settings. This is why the company recommends 60 to 80% power settings. So you can see that spike in the middle, that basically shows instantaneous tissue contraction. Energies below 60% did not produce peaks that ended up in that sort of colored stripe. It says instant tissue contraction, so therefore it is not recommended. Now it literally happens instantaneously. I mean, within well under a second. So as long as you get those temperatures, which is above 85°C, you get instant contraction. This illustrates the difference between instant tissue heating versus bulk tissue heating. You can see the two different lines. You have the yellow line on the graph and the orange. The yellow shows instant heating at 85°C. It happens in approximately 0.044, I think 0.044 seconds. We won't get to the exact numbers in a second, but you can see it's well under a second. When you're bulk heating, like some of the other RF type devices, the problem there is you have to heat all the tissue around, and you can't heat it too much, otherwise you can cause the heat to travel to adjacent tissues, causing injury to tissues you don't want to injure. So you have to keep the tissue temperatures down to about 65°C. At 65°C, it takes a much longer time to get any sort of contraction at all, and the best you get is about 40%. So optimal temperatures for thermal contraction. And this just shows you the difference between 85°C versus 65°C or even 70°C. So greater contraction can be achieved with higher temperatures and shorter treatment. So again, to illustrate, at 65°C, collagen contracts approximately 40% in 2.5 minutes. At 70°C, you get about the same amount in about 42 seconds. At 85°C, you get 60% in 0.044 seconds, almost instantaneous. So when you're treating with 85°C, you get 50% more collagen contraction than you do in 3,500 times faster than compared to 65°C. And you get 50% more collagen contraction and 1,000 times faster than at 70°C. So it's obviously much more efficient. And there are other benefits to this as well. The biggest benefit is safety. So you have a very precise control of the delivery of the heat and the pattern of heat. And the reason of this is you don't have much thermal spread because the temperature heats instantaneously and the heat does not diffuse into the surrounding tissues. You do not get bulk heating. The rapid heating also has near instantaneous tissue cooling. And that's just because the tissues being heated is a very superficial tissue, meaning the collagen surface that you're treating under the skin. And this shows much less diffusion of heat to the skin itself. Studies show that during subdermal use of Renuvion, temperatures at the surface of the skin does not rise by more than 4°C. So you can see this picture on the side here. There's is this actually a video as well on the side? Okay. Okay. All right. So which is weird. They did play it before. I know. All right, let me just try one more thing. Nope, that didn't work. So this was a treatment of an inner thigh, and you see the FLIR camera showing the infrared temperatures of the various structures. You can see those lines. Those are lines that were treated in one of the passes. The highest temperature is 35.1 C in the top left of the of that little screen within your screen. So literally that's the highest skin temperature that we achieved after a full treatment of the inner thigh. And the inner thigh skin is relatively thin as well. And you can see the diagram at the bottom. It shows you're getting 85 C in the deeper tissues, and literally just a few millimeters above, you're only getting about 41. Well, it's less than 41 C. You'd never really even reach 41 C. And there are ways to increase the temperature of the skin, which you don't want to do, and we can talk about that when we actually do the procedure, like how to avoid it. So the energy has been being delivered in essentially two ways. You have the direct contact of the helium plasma, which heats the surface of the fibrous septae. And then you have the flow of the proprietary RF through the fibrous septae, which also causes contraction of the fibrous septae. So it's considered two different ways the energy is treating the tissues. You also have a 360-degree energy application because of the way the tip is designed. They have these side ports, and the energy can arc from one side or the other and in multiple angles. And in doing so, it can hit basically a 360-degree ring around the tip, around the sides. And there's value in this design, and we can talk about that when we actually do the procedure. But one of the more important values is it's diminishes the risk of end hits because the end does not deliver energy directly, and you get energy to the sides as the tip is passing across the collagen, which is essentially the optimal way to deliver the energy. These are just some references. Various people have written papers to show why it works and how it works. This is the generator itself. For those who haven't seen it, this is the newest iteration. On the left side, you have the standard electrocautery. You have your monopolar settings, just like you do on any electrocautery you've used in the OR. You have your basic bipolar. By the way, it's a very good electrocautery. It's probably the best one I've used just as electrocauteries go. On the right side is all the Renuvion stuff. So the top is your energy percent. So it ranges from 0 to 100%. The company does not recommend going above 80% because those numbers have not been validated, and you get all the treatment you need at 80%. So there's no reason to increase your risks with higher energies. The second number is gassed flow, and that's in liters per minute. They recommend 1.5 to 3 liters. Anything below 1.5 doesn't seem to deliver the energy quite as well. And anything over 3 is in general wasteful, and you get complications potentially of having helium extravasate into other parts of the body you don't intend it to go. On the bottom, there's a couple of other settings. The main thing that you'll want to see here is essentially the joule counter. And that doesn't necessarily correlate to the endpoint. However, it's a nice thing for us to follow. I like to know how much energy I've placed into an area. And that's, I think, just because we're so used to using lasers and other things, and it's nice to have some number you can write down. You can also see there's two little lights there. Well, there's one lit up, it says tanks. That just shows that your helium tank is hooked up in the air and it's flowing. You have the various connectors at the bottom. The handpiece for the Renuvion is over to the right, and there is actually a little port. You can see a little metal circular thing in the center. That's where the helium gets delivered through the handpiece into the patient. So the joule energy information. This is just to have an idea of how much energy you're delivering while you're actively treating. So at 60% energy, you're delivering approximately 13.9 joules per second. So it just shows essentially for minutes of activation how many kilojoules you're delivering. And up to 80%, you're delivering approximately 19.25 joules per second. So in general, you deliver approximately anywhere from 1.2 to 0.9 kilojoules per minute. Are these numbers upside down? In any case, energy effects on tissue. These are the following. These following different points contribute to an increased amount of energy and heat being delivered to the tissues, which can increase risk of injury. So let's just start in this circle. Let's start with number 1. Moving too slowly over the tissue or passing over one location over and over again can cause overheating, and that's obviously not necessarily a good thing. Performing multiple treatment strokes or pass over the same tissue, very similar, but also that can cause issues. Overlapping or cross-hatching without allowing for thermal relaxation. So if you need to go back over a certain area, just make sure you have given the tissue enough time to cool off before you go back and heat it up more. If performing combination therapies with other energy technologies, you should be cautious because, again, that's more energy. So there are people out there who have done things like Renuvion and like an RF microneedling or something at the same time. So if you do something like that, be cautious. Increasing the power setting over 80%, again, not validated. There are people who do it, but it doesn't necessarily, there's no data to support that it is necessary. And you are probably increasing your risk. Activating while in direct contact with distal tissues or structures. So this just means you don't want the tip to be sitting in one spot and pressed against tissues when you activate. You ideally should start pulling it back before you activate. However, if there is gas flowing, the risk of this is relatively low. Tenting the handpiece towards the dermis. Again, you're just kind of getting the electrode close to the skin. And also you're thinning the tissues and therefore delivering more energy to the thinner dermis. Treating non-tumescent tissues also seems to increase thermal damage. The tumescent solution will help diffuse the energy to some degree, just because of it'll allow for the heat to reduce quickly, just because it's being absorbed by the tumescent solution. Previous surgical or aesthetic interventions or to the treatment area. So if the patient's had surgery in the past, there is slightly increased risk of complication. This is likely just because there's either less fat, maybe there's less tumescent solution in the area, and also more collagen due to scar tissue. Not to say you cannot treat areas like that, but those are things all to keep in mind when you are treating areas that fall into any of these categories, or you intend to use techniques that fall into those categories. Pearls for success. So your settings should be 60 to 80%. Helium flow 1.5 to 3 liters. You want to properly tumesce the area for anesthesia, especially if the patient's awake. But in either case, you want to make sure you use tumescent with epinephrine in it to minimize bleeding. This is partially because obviously you want to minimize bleeding for the health of the patient, but also for the health of the handpiece. A very bloody site will cause the handpiece to fault. Effective undermining. This is also very important. You can use any cannula, ideally a cannula slightly larger in diameter than the handpiece itself. This releases tissues in the area, allows the handpiece to slide smoothly and not occlude helium flow as you're trying to deliver energy. And the handpiece itself really isn't designed to undermine, and you will clog the tissues into the handpiece. It's not designed for that. So you want to make sure that you properly undermine first. You want to make multiple incisions so gas can escape while you're treating. Otherwise, it will build up internally and can extravasate into other areas. The technique that's recommended that has been validated is a speed of 1 to 3 centimeters per second, meaning you move your hand back as you're delivering energy at a rate of 1 to 3 centimeters per second. The stroke distance, meaning how closely you place each stroke. So we're talking each stroke is each time you bring the handpiece back, and a pass is when you go across an entire area. So the distance between each stroke should be between 2 and 3 centimeters. If you space them too closely, you increase the risk of bulk heating. At the moment, activation on retrograde only. And this will help prolong the life of your handpiece and to make sure it's operating appropriately and decrease the risk of end hits and burns. You want to do anywhere from 3 to 6 passes, and this depends on a number of things. One, how quickly you're moving, and the thickness of the area you're treating. The thinner the tissue, the fewer the passes, and also probably the faster you want to move. The depth of treatment also are things you have to keep in mind. So you can treat at different depths depending on how thick your tissue is, just to hit the fibrous septate that you're trying to treat at different levels. In thinner areas, of course, you can treat it as a single depth. These are the handpieces. Essentially, there's a long and a short handpiece. The new handpiece has been improved significantly from the old handpiece. There's a rounded tip now, which minimizes the insertion force and cause less blunt impact to the tissues. The previous handpiece had a flat tip with the opening at the very end. The entire shaft of the handpiece is flexible now, so you can contour around certain body parts. It's 40% smaller in diameter. It used to be 5 millimeters. Now it's 3 millimeters, which obviously is nice because you can make a smaller incision. And you have the side firing, which targets the tissue better. These are some case examples just to give you an idea. And this is, of course, just an idea of how these things go. These are not necessarily the best case scenarios, but probably somewhere in the middle. And in some cases, they may not even be even average. This is a case where a patient had some irregularity from previous lipo, but also had some skin laxity and some adiposity. She had Renuvion done to the upper abdomen. This is still early in the healing process. You can see there's still a little bit of irregularity, which will even out. But you can see how much that skin has retracted. This is an arm before and after. Again, you don't see a huge change in this arm, but you do see a little, some improvement in the upper arm. Here's a patient who had it done to the neck. You do see a pretty significant improvement in this patient. This is a patient who had very lax fibrous septae in her whole body, and she actually got a better result than I would have expected considering how loose her skin was. And again, you see the before and after, especially the laterals where you see most of the improvement. Now you can see even better results than this depending on the patient, and this patient selection is very important. Here's a patient who had it done. She actually had a short scar arm lift and a different RF technology prior and wasn't happy with the results. After Renuvion, you can see that the laxity in the posterior arm is essentially gone. But the interesting part is you actually now see some significant tightening in the medial arm. This is still on the early side, and a lot of those little crepey things will go away. That is something to consider, though. Patients, especially in arms and crepey skin, you will see sometimes that sort of that bunching of the skin temporarily. You can also see how her short scar brachioplasty incision has been pulled distally towards the area that was treated. So there's definitely tightening of that area. Another patient who had Renuvion only, no liposuction. This was done under local. You can see there's some improvement of the definition. The most important thing in this one that is not being demonstrated is the skin is far less lax, meaning you can't pull it away from her as much. She obviously has had other surgeries as well. This is a young patient who had liposuction and Renuvion, and she had a very nice result. Same patient, you can see how everything is nice and tight and smooth. Now it's true this patient is young and therefore may have had a decent result anyway, but the amount of tightening she had was really exceptional. Same patient. This is our patient today. So this patient is, I believe she's approximately 55. I don't know, it's approximately 54 or 55, I believe. And she has had some minor procedures in the past. I think many years ago, she's had a brow lift. She had upper blepharoplasty, and I think she had I think that actually may be it. She has a scar on her right, the right side of her face due to, I believe it was an excision of some kind in front of her ear, but it has not had a lower facelift. We're going to be doing this procedure with local tumescent and Pronox. For those of you who don't know who Pronox is, it's basically nitrous oxide and oxygen mix 50-50. And it's a device you can purchase for your office use. And it doesn't really need any regulation because of the way it's mixed. The patients really can't OD. And another nice part is it works well, and the onset of action is quick, and the effects of it dissipate very quickly, so the patients can theoretically drive themselves home. These are my markings. You may come out with your own markings in the future for what works best for you, but these markings show essentially the various vectors and the areas that I want to treat. So the nasolabial folds, there's that fullness that many patients get. I like to place a little bit of extra energy in that area. I will often mark the mandibular angle, the edge of the margin of the mandible, and then the cervical mental angle. This just gives me different areas to treat, and you can also treat all the way down the anterior neck, all the way to the clavicle if you choose. I use a total of 5 puncture wounds, 1 behind the lobule on each side, 1 in the temporal area in the hair-bearing skin, so we can treat a little bit higher up and get a little more of that upward vector, and 1 directly in the submental region. And that's it. Now I'm going to run downstairs and get everything started so you guys can come and watch us do it.
Okay, so we're off mute.
Actually, can you sit her up a little bit? A little more. That's good. Thank you. Okay, we're good. Okay. All right. So our patient is fully awake, just calm and calm. Yeah. Okay. All right. So she actually chose not to do Pronox, even though we often do, which is fine. So we're gonna just numb a little bit first. So I numb the entry points, and the rest of the numbing comes with tumescent. So we're using this, yes. So we have. We're gonna hang that. This is a nice little contraption. Obviously, you don't have to use this. You can use it many different techniques. You can use just a syringe. You can use a cannula. I mean, this is just a 21 gauge needle. And actually, these are a little smaller. Can I have a 25 or something, or 27? Just for the insertion. And this is nice because it has a little spring on it, so it kind of fills itself. Yeah, it's good. So the tumescent I use, and everyone may have, you may all have your own concoction. Can you open this for me? No, sure. Yeah, thank you. All right. My concoction is 100 cc's of NS, 50 cc's of 1% lidocaine with epinephrine. And do we have any bicarb? Oh. Let's go a little bicarb in that. Oh. Yeah. So it's sorry. Let's start over. It's 100 cc's of NS. It's 50 cc's 1% lidocaine with epinephrine, 20 cc's of marcaine, 4% plain, and 20 cc's of bicarb, which I'm going to put in now. The reason the bicarb is because otherwise it stings a little, especially with a patient. The reason I use marcaine, which you don't have to use, but I use it because we're doing this in the office, and sometimes office days can be busy and patients come in and you may have to like step out for a minute and see somebody. If it takes a little time to come back, the patient's still numb. If you use 1% plain, sometimes they're not, and you have to kind of start over. So that's why I like the marking.
We're working on getting the video up. Dr. Rogers is just going to start infiltrating his patient while we work on the visual aspect of things.
Sneeze a little bit. Okay, so you can start from whichever area you want, but the areas that I too much, actually, do a marking pen. Can I have let me mark everything so you guys see the areas that are at treat. You do enough of these, you probably don't even need to mark anymore, but for today's purposes, for sure. She doesn't have much of a gel, but those who have gels, sometimes you mark all the way down like that. Then I like to do one line this way and one line this way, just so it creates zones for me. And you can do a middle line, midline if you want, circummental angle, and sort of the extent of where you want to treat. Thank you. All right.
Dr. Rogers?
Yes.
Can you just talk a little louder?
Oh yeah, no
Thank
problem. So the approximately, I have under 200 cc's of volume total. That should be enough. Now, we'll get to the bicarb part. If you find this isn't quite enough for you, you can always increase the volume. But I find that if you have too much tumescent, it's it's probably not ideal either, just because it's just, you get all this fluid in there, especially if you're not going to be doing any liposuction. Now, if you're going to lipo, and a lot of these patients, you may lipo a little bit as well, that's less of an issue.
How much infiltration do you normally put in a patient?
We put in, it's probably about 150 cc's, or it's, you know, give or take. It kind of depends on how much neck you're doing. The neck is kind of the one thing that can increase the amount you use. If you're, some people, if you're just doing sort of just this area, you don't need very much at all, under 100. But in her case, we're probably going to use the whole thing, which is almost 200. I try to infiltrate about a centimeter past my markings.
What would you say is the most common procedure you do with Renuvion?
So I think the face and neck is probably one of the most common, but arms is also extremely common. It works very, very well on arms. So the best arm you want to pick in terms of the patient you want to choose for arms is somebody who has a little bit of laxity, but not necessarily someone who's very, very lax, and they're just not going to get the result you're looking for. And you also don't want a patient who's too elderly. So any female who's above 65, I'd be very cautious in terms of giving them any expectation, because in some of those cases, they will lose a little bit of volume, even though you tend to preserve volume with this technique, but they may lose some and they may not get as much tightening as you hope. Cases like that, if they really, really want to try this, I'll still do it. I'll just tell them, look, there's a very good chance you're going to need a lift if this doesn't work. Anybody who's younger than that tend to get very nice results. I think your ideal patients are probably those that are between 40 and mid to late 50s.
And do you work circumferentially, or?
I do like to work circumferentially. You don't have to, but I think you get a better result when you work circumferentially. I mean, obviously the skin goes all the way around, and therefore the laxity is technically all the way around. You just see it down at the bottom. Men, I think, are a little bit different. I've only treated a couple of male arms because men don't tend to have as many issues, complaints about their arms, but every once in a while you do get somebody. I think men in general tend to respond better, at least in terms of age-wise. So they seem to get a result even if they're on the older side.
One of the other questions people ask is, do you see that you tend to have a regress, or that sometimes they take a step back before they take another step forward in the results?
Yes. So that one arm that I think I showed you, see that you can get sort of like a crinkliness of the skin. And that sometimes is a step where you get all this fibrosis in the deep plane and the skin just kind of crinkles up and you get sort of like hard spots and things. And that can look bad, but that goes away. I've never had that not go away. It does happen, it tends to happen more in certain ethnic groups, I think. I see that a little bit more in Asians and people with a little bit darker skin. But it also tends to happen, it seems to happen more only in like areas where the skin is very crepey and thin, like the arms, for instance.
We have someone from the audience asking, what is the infiltration device you're using right now?
So this is a device I think we order from, I'm not sure where, I think you get it from McKesson, but other places as well. It's just all it is a control syringe, 10 cc with a spring. And you have a little three-way arm there that hooks up directly to the IV bag. It just makes it a little bit easier to inject. Of course, there's probably 100 different ways to do this, and they all work. You just have to get the tumescent solution to the right plane. I mean, this is a very important step. You want to make sure in the set 2 plane, you're not deeper. So those of you who don't do this kind of thing on the face very frequently, it just take some time to get accustomed to the anatomy, because if you infiltrate the wrong plane, that's also the plane you'll have a tendency to treat. And if you treat deeper than the SMAS, then you have a very high likelihood of injuring a nerve branch, which obviously none of us want to do. The fortunate thing is if you do injure nerve branches, they tend to recover over time because you're not cutting the branch, you're just heating it to some degree where it may shut down. But the nerve branches that aren't cut tend to recover pretty well, usually over about 6 to 12 weeks.
Another question is the endpoint you're using for this infiltration. Are you looking for a volume or for the distension, the tautness?
I am the film. When you actually when you inject, you can see the tissue sort of fill up a little bit. So I just make sure I have a little bit of fill throughout everywhere. And you can tell that there's fluid in there. That's how I go about doing it. If you're doing this for liposuction, I often use more. And then I don't mind if I blow the whole face up, and you're going to take it all out. So other areas I tend to use Renuvion that I think it's very useful, and I tend to recommend it to almost everybody in the liposuction these days, is the inner thigh, because the inner thigh is very likely to get irregular, even in relatively young people if you hope to take out a fair amount of volume. And the abdomen is probably the second most common place I recommend it. That and also the bra rolls. I think it does very nicely there. You can use it anywhere. I mean, I've used it on ankles. I've used it on forearms. I've used it. Literally, I've used it almost the whole body.
Can you tell us a little bit about your breast procedures?
Oh yes. So I have done quite a few. It's not like I have a huge series or anything, but I have done quite a few breast lifts with Renuvion only. Meaning I treat the breast, but I don't remove any skin surgically, no big incisions. And I've had some good results. I can get the nipples to come up a couple of centimeters. The breasts do seem to shrink a little in size, but it's kind of hard to tell if you're actually losing volume. I haven't done a volumetric study yet, which may be worth doing. I have a Vectra, so I probably could do that. But when you do a mastopexy, just a standard mastopexy, you're not really removing any tissue, significant tissue. They still look smaller when you lift them. So that might be part of what's happening. I find that the patients that do the best are those who just have some relatively mild ptosis, and they don't have nipples that are obviously too far off, because you're not going to get more than a couple centimeters of lift. I've also done them over implants, though those are still on the early side, so I don't know quite how they're going to turn out yet. It does take I would say probably anywhere from 4 to 6 months really to see the full result. So I tend not to judge until I've had that time. I have also done a couple of cases where I've done the Renuvion to the breast, and then I've added fat also. Now this is something that you have to be a little careful of, just because it's sort of doing two different things to the same area. But I have had nice results, seemingly nice results there too, but again, on the early side.
On your breasts, what type of post-care do you do? Do you tape? What type of garments? How long?
I just put them in a surgical bra, and I think that's fine. But I have also done other things too, just to offset some of the forces. So I have taken tegaderms and positioned the nipples in a higher position and tegaderm them there. And just I figure if there's less forces on the fibra septae or the Cooper's ligaments in this case, while they're trying to contract over time, maybe you get more contraction. That's just theoretical. All right, we're just about done. So now I'm just going to make sure I go towards the margins and just do a little extra, just in case I pass point a little. I don't want her to have a bad experience.
I have a question.
Yes.
Do you use or do you recommend using it to treat cellulite?
I have used it for cellulite. I don't think it's going to cure cellulite, but I do think it'll improve it depending on the type of cellulite and where you're treating it. I have seen it improve, like for those younger patients who kind of have that light cottage cheesy stuff. I think it does improve that.
With
Yeah.
lipo or without? Just-
I've done both.
Both.
Either way, you're going to be doing some, significant undermining to get into the plane. I have also used it on the buttocks, and I've seen some pretty nice buttock lifting.
Mhm.
But if you're going to do that, you have to do quite a lot of passes at a bunch of different depths. Let's see, where else have I used it where I really like it? I used it on men's chests. That seems to work quite nicely. I don't have a case yet where I can say I definitely raised the nipple position significantly, but I have been able to get some when patients, the slightly older men who have a little bit of loose skin, to get the skin sort of shrink and stick down to the pec contour. Okay.
We have a question. This was brought up at our users meeting. We had a lecture on this.
Yes.
Can Renuvion be used in patients with lipedema?
Yeah, I don't see why not. I mean, lipedema is really just an abnormal collection of fat in the lower extremity for the most part. And if you're doing liposuction there, you can use Renuvion. Anywhere you can liposuction, you can pretty much use Renuvion. Not to say you have to liposuction if you're using Renuvion, but if you can lipo it, you can Renuvion it. Okay, we're pretty much done here.
Do you have any additional pearls on avoiding nerve damage?
Well, right now I haven't really done anything in the forehead because the frontal branch is kind of in that plane where you're very likely to hit it. So I haven't done that, though I'm sure someone will come up with a good technique to avoid it. I know people are starting to do it. But other than that, really it's just keeping in the superficial plane. Make sure you're sub-Q. And the most important thing about sub-Q being in that plane is where you TMS and then where you tunnel. Where you tunnel is where you're going to treat. So yeah, 15, please. 15. So again, just a little puncture right behind the lobule. I like to put one here, though you don't necessarily have to. This is, I find a good results when I do that. And then right here. In patients who have really severe, like jowls and nasolabial folds, you can put a little puncture under the margin here, the mandible, and come up this way, and just a little more direct. But for the most part, you can treat this from here if it's not that big of a deal. In her case, it's not. Can I have the? So I like this one. This is a 4 millimeter, but you can use a 3. It's spatulated. I like it for the face. The thing you have to be a little careful of is you don't necessarily want to undermine or tunnel so much that you're basically breaking everything. So it's just like a flap of skin, like you're about to do a facelift. Because then what are you really treating? So you want to make sure you keep some of those.
And the result you see like immediately, or what's the time frame you see the best?
Depending on what part of the body you're treating, in some areas you can see some tightening of the tissues right away. Like on an abdomen, for instance, it's quite loose. When you pull up on it after treatment, you can pull up only half as much. It's actually quite impressive. But in terms of the final and overall tightening result that the patients are looking for, I tell them to give it 6 months.
6 months.
Yeah, you'll see improvements. Kind of, it's like a stepwise progression. You may see some edema at first. I mean, just like liposuction, you have some edema. But with this, I find you may have like sort of little lumps that can last a little longer. Probably just because you're adding heat and you need a little more energy to it all. But it does take some time, I think, to get the full result. I had this one patient who I did Renuvion on and aggressive lipo, and she also had lupus. So I was a little worried about her, but she said she's had lipo before, not a problem. So we tried it. She got a big seroma on her abdomen, probably because I over lipoed. I just was very aggressive. And it took a long time for that to go away. It looked all wrinkly and horrible. Like, oh my God, I'm gonna have to do a lower tummy tuck. Over about 4 months, it completely shrank and flattened, and now it's perfectly smooth. So it obviously does something. It just takes a little time. Remodeling takes a little time.
What are you using to undermine? What is this?
So this is just this is a 4 millimeter spatulated lipo cannula on a handle, but it's not hooked up to anything. Sometimes you can do this just so it doesn't dribble on you, or you can hook it up to a tube and not put it on suction.
I like to spatulate it on the face, doesn't have to be. But it's just my preference. I use this one for if I'm actually doing real liposuction as well. You can see she's comfortable. I mean, she's not making any faces. You okay? Okay. Now, this is more comfortable than the numbing part, right?
Mhm.
The numbing part can be uncomfortable sometimes. That's why the bicarb. So I like to come up this way. This is always the hardest angle to get because you have some connective tissue right there. Just so I can get up into.
Will you actually cross the marionettes and nasolabial folds?
I don't actively cross them, but if I do a little bit, it doesn't bother me. But I try not to actively cross them over and over again. I come right up to the edge. My fear is if you actively tunnel too much across them, then you're right. So yeah, it's that past point a little bit there. If you actively cross it too much, you may break down all that connection. You don't want to lose the nasolabial fold because that would look odd. So even without suction, a little bit of that comes out. There we go. I try not to treat directly over the mala, though he probably could in someone who had really sort of chubby cheeks. But for the most part, I don't want to reduce any volume. Now, I don't think you get a lot of volume loss, especially in young people. But anytime you add heat of any kind, I think you probably get a little bit of volume loss. Now, it would theoretically make sense that you would get far less volume loss with this than you would with bulk heating, because you're really just preferentially treating the collagen, because that's the most conductive. And bulk heating, you're treating all of it.
Another question here.
Uh-huh.
Does the heat cause any lymphatic drainage issues?
I've not seen it. I've not
Any
seen
injury? No?
I've not seen any lymphedema or anything like prolonged swelling that I would call lymphedema. I mean, you can have a little bit of prolonged swelling like you do with lipo, but not anything extraordinary.
I get a lot of people that will question whether or not they should treat arms if people have had reconstructive breast cancers or lymph node dissections. What are your thoughts on treating arms after that?
I do it all the time. I do a lot of breast reconstruction. I do a lot of lipo and moving on 2 arms. I know there's people who are anxious about it. Sometimes the breast surgeons are anxious about it. Sometimes the oncologists, the hemo docs, they tell their patients, oh, don't ever do that. But in fact, in the literature, lymphedema, one of the treatments for lymphedema is liposuction. So if you are removing some of that fat and then what was that noise? If you're losing some of that, removing some of that fat and closing down that potential space, then you have less space to actually swell. So I think Renuvion might be an excellent choice actually, because you're shortening all that fibroseptate and decreasing the area for lymphedema to actually occur. One of my beliefs about lymphedema, by the way, is that I think that the main reason for lymphedema isn't necessarily just the disruption of the lymphatics, but I think it's also the scar tissue. So the scar tissue, I think, acts like a dam and prevents the lymphatics from reestablishing, just like your vessels naturally will reestablish, even the hip injury. And it prevents fluid from flowing in a more beneficial way. So if you can break down scar tissue in the axilla, and I use a lot of fat grafting, I find that I get about 50% reduction in lymphedema in patients who are treated for that, which is about as good as you can expect with any technique, even these sort of lymphatic repair type of micro procedures.
You mentioned the success with medial thighs.
Yeah.
Can you comment? I mean, do you think some of that is as a result of a different mechanism of action than other RF energies, or do you have certain pearls or suggestions on how to maximize those results?
Medial thigh, I mean, literally, I'm gonna get a little more. I mean, literally, I just think it's just, you just go in and basically have to treat all those fibroseptate. That area tends to be a little loose on people anyway. And then whenever you hollow it out, there's a tendency just for it to become a little bit irregular, even if you did the best possible liposuction you could. So it's not that I haven't necessarily a pearl other than just treat it as per what the company recommends, and that gives you good results there. But after lipo, you do lipo first, of course. Okay, just a tiny bit more, a couple spots. All right, on to renewing. So the first thing we do is we just make sure that the gas is flowing and everything's activated. So you can hold anything that's metal. You're conductive enough to at least see it work. Yep, so that's working, it's arcing. The only reason it arcs is because the helium is flowing, otherwise it wouldn't arc. So you know everything's okay. Our settings are 60% energy, 1.5.
Can you mention why you chose those?
Well, all right. Well, 60% energy, first of all, that's what the company recommends for the face. But the reason they recommend it and the reason why it makes sense is because the skin of the face tends to be a little bit thinner. And you don't want to put very high energy into area with thin skin. 1.5 because the face is a relatively small anatomical area. And if you put too much gas flow in there, it'll just start going everywhere. Like it'll start going down to the chest. And sometimes you can have some chest pain associated just with the helium there. So you really want to prevent that. Now, it may happen anyway, so if a patient complains of chest pain post head neck treatment, tell them, I mean, obviously make sure they're not having something happening, but for the most part, almost for sure, it's just a little discomfort from the healing. But it would almost guarantee you do enough of these, you're going to have an anxious moment where you're like, oh no, what's the chest pain from? But it goes away on its own. Another thing that when we do this, you'll see there's another thing that I do to really help prevent extravasation of helium, because the helium wants to go in lots of different places.
So you use your non-active hand to control
Yes.
where the helium goes.
So for, yes. So, I mean, in cases, one place where the helium likes to go is up and around the eye. So you can, when I start shooting this area, I try to block it with just a finger. And it does work. Even if it does go around the eye, it's not dangerous, it just looks bad. You can press it out. So I tend to like to go a little faster than 1 centimeter per second. And the reason is I feel that you're getting instantaneous contraction. I mean, so literally you're getting contraction faster than you're moving. So why go slower? Because the slower you go, the more heat you put into one area and the more likely you are to overtreat something. In rare instances, you can get someone who responds by producing a lot of fibrosis to the energy. I have, I think, one or two patients who are like that, so I'm just waiting for it to all to settle. But they're definitely a little bit more densely fibrotic after a treatment than the average. And you can treat those also with steroid. If you get someone like that, you can inject them with like a Chemalog 1 or 2, where you just take your Chemalog and just sort of inject them in the area. That really does help decrease some of the fibrosis that they may have. You know, every patient's different. That's what keeps us hopping, right?
I have a couple questions
Yeah.
here. How long does it take to achieve the maximum remodeling after the procedure?
Probably about 6 or even possibly up to 9 months. So I've had some patients at 6 months, I think they're done, and they come back a couple of months later and it looks even better. So I would say probably up to 9 months, maybe even a year. I just don't think anyone's really measured that far out.
But what do you see as their kind of initial first 2-3 weeks? What do they see?
First 2-3 weeks is mostly swelling. So you're going to have some swelling. You may have a little more swelling than you would with just liposuction because you're adding heat to the mixture, but it's not that much more. You can sometimes have lumpy, bumpy swelling, so you can have little areas that seem a little bit tethered, and other areas seem a little bit full and firm. All those go away. So on the face, what I tell patients is the first week you'll be very swollen and not look like yourself. The second week you'll kind of look more like yourself, almost like you haven't had anything done. The third week is when you start seeing some of the improvement, and you'll start at that point they'll start seeing some tightening and some slimming of the contours, and that just keeps getting better and better.
I see you marked your lateral border there on the sternocleidomastoid. Have you worked posterior to that on your neck?
I have not. I don't think there's a lot of benefit to that. because this skin is very tightly adherent in almost everybody. So even if you can treat it, I don't think there's any harm in treating it. But I just don't think you're going to get much benefit just because, and unless they have horrible loose skin here, but most patients don't. Most of it is anterior to that.
If you weren't doing the upper face, where would your other incisions be?
I would not do this portion. I would still do this one and this one. Those are the standard. I think most people, that's what they do for neck liposuction.
Have you predetermined how many passes you'll make on this case?
I usually do about 3 to 4 passes. So I don't think you need to do that many passes in the face. All right. Okay. So this is to try to get in that easily little fold area. So here's where you want to kind of press the gun from going into the eye area, the orbital area.
What type of garment will you use on her after?
We put her in a jaw bra type thing, basically just a strap. They have nicer ones that have a little chin cup and a little bit softer. Essentially, that's all. We'll put a little bit of gauze behind the ear to catch any sort of dripping that might happen in the first 24 hours. So this is, despite my best efforts, there's almost always a little bit of healing gets up around the eye. I'll show you as soon as we're done. I'll show you one eye compared to the other. I'll show you the easiest way to treat it.
Okay, I've got a longer question here, coming from Europe. My question is about the number of passes, taking care about stroke distance. You said that 3 to 6 passes is necessary, gas flow 1.5 to 3.
Yeah.
How do we decide what is optimal? Is it based on the tissue thickness? Is it more about it's a skinny person and you do less passes on a skinny like 3, or more passes like 6 for a thicker or fattier persons?
Yes, so the answer is yes. But yeah, so on the thinner person, you want to do lower energy, fewer passes, or you can just move your cannula or your handpiece a little bit faster and do more passes that way. On a thicker area, you definitely have more leeway. So you can increase the energy, do a little slower. The risk there is much lower. The interesting thing is, according to the data currently that the company's collected, whatever your technique is, pretty much everyone gets similar results. So I truly believe that the vast majority of the effects are happening with the first pass. I really do. I don't think there's anything to validate that 100%, but that's my personal belief. Now you can see here. See, she's got some gas around her eye. This is not bad. Sometimes it can be a lot worse. It's very easy to get that out. It's not painful, but the patients sometimes when they're trying to go home and they can't see because everything's all swollen, it's a little bit disconcerting. So just press it out. It's gone. Yep. And so this is also how you clean them. So every once in a while you want to do this. So you want to activate, use this toothbrush, and push out any carbon that may build up. So I don't know what you can see on the camera, but there's a tiny little electrode in the middle of that, and there's basically a hole that goes all the way through these two sides. And any tissues that get on there, and usually it's blood, it gets on there will carbonize and stick to it, and eventually it'll block the egress of healing. So you want to make sure that doesn't happen. And doing this every so often before it alarms is ideally what you want to do. So when they say the spacing should be 2 to 3 centimeters between strokes, but that doesn't mean you go in the same spot every time. So you do one pass, 2 to 3 centimeters apart, and then when you come back over, ideally you want to split the difference and go between. So you try to treat as much of the tissue as you can. Now, if you have enough time to cool, which doesn't take much time in this, you can go over the same path and treat it and not cause any problems. You're just probably not going to get maximal benefit because most of those tissues have already been treated and they've already contracted maximally. So putting more energy into them isn't going to make them contract anymore.
You mentioned anywhere that you treat with liposuction, you can use Renuvion.
Yeah.
How does that correlate to your consultations? Is this an option, an add-on? How do you present it?
So the way I present it is it's an add-on, and it's an add-on for areas where you're more likely to get irregularity. So of course, it's not like, people say, oh, well, that means you're not going to be a good liposurgeon, right? It means you're going to cause irregularity. Well, I say, look, I do more lipo than most people, and the best liposurgeons are looking at irregularity in these areas, because these are areas your bodies have a tendency to become irregular. And so if you want to reduce that risk maximally, this is the best technology for it. Of course, there are patients also who are just those patients who you worry about because they're that age, like anyone, in their upper 40s and up. Well, I would say probably 40s to like mid 50s are the most likely to show irregularity. Their skin's kind of thin, but their fat hasn't gotten all soft yet. And so those are the patients that are more likely to get irregular than the other age groups. And so those patients that I'm lipoing them, I say, look, this will help you get the best possible result wherever we do lipo. Now, that doesn't necessarily mean that they are going to want to add on extra cost everywhere, but often they will. When people come to you to try to get the best possible result, that's always the reason they're here. So if you tell them spending a little more money will give them the best possible result, then you're open to that.
What kind of sedation do you use for the patient? IV or oral?
For her, this is local only. Did he give you a pill?
Xanax.
Xanax, okay, so she has Xanax. Yeah. But it depends on your patient. If you have a high anxiety patient, obviously more. If you have a low anxiety, sometimes they don't, just local is enough. But you can also do this if you're doing like, full body lipo under general, of course you can do this then too. And I do that quite frequently with a lot of my cases. But this can, smaller areas like this and our arms can definitely be done in the office. Arms, you have to use a little more tenacity, and you have to let it wait a little bit, because if you try to jump the gun and do it before it's really sat for a while, invariably there's spots that are not fully anesthetized, and they do, they're like, oh, ow, and you have to kind of give them a little extra.
Do you notice on your necks, I know on her pre-op, she had a few necklace lines that were low. Do you notice that afterwards that they're visually improved?
Yes. Now, when people like say, but it's not gone. Like, of course, not gone. You were born with those. That's part of your, your phenotype. That's the way your genes have designed you to be. But they will definitely be less evident. And of course, they'll argue. People are like, I didn't have them when I was younger, but they did. Okay. That's one side. Just for everyone's curiosity, we put in about 3 kilojoules on that side. Now here, when I treat, I do cross the mandibular angle margin a little bit. So I do a little bit of cross hatching of areas, which I don't think is a big deal as long as you're not treating it immediately, retreating it from a different angle. You give it a moment for it to cool. In the face in particular, because the skin is thin, you can feel the skin gets a little warmer to the touch. It's still not getting that warm, but you can feel it. If you're treating, like, say, the thighs or abdomen, sometimes you can't even feel the difference at all.
If you were to get a marginal mandibular nerve trauma injury, how do you treat it?
Just watch it. That's the best thing. Conservative. Just let it, recover on its own. If they're a high maintenance patient or really cares about the slight asymmetry, you can do a little Botox on the other side for balancing. The nice part is it often takes about 3 months for those nerves to recover, and Botox lasts about 3 months, so they both wear off about the same time. And you're not going to be transecting a nerve with this. The worst thing, and it's unlikely the energy is actually damaging the nerve. Most likely what you've done is dissected the wrong plane and dinged it. So that's the most common reason to have the nerve injury.
What type of post-op medications do you give them to go home? Do they need anything?
I mean, around here, patients tend to need more than probably other places. But, so I usually give them a few narcotics, like a couple of narco or something like that. But other than that, they really don't need much. I mean, I usually don't even give my patients this type of patient antibiotics. If it's other parts of the body, then I will. For the face, I typically do not. You can see a little bit of nerve activation around the eye. Yeah, I go through here and see if I can get it. Yep, okay. So that's just because we're using RF. It's electricity that activates nerves. Okay. Okay, again up here, try to get more energy up here. Oops, see, I didn't block it. See what happened? Okay, breathe. Then you just press a little bit. Down. So that'll happen. If you come up in this area, that'll absolutely happen to everybody here. The younger the patient, the less likely that happens, but it's still going to happen.
Do you close your incision sites?
Not on face. They're too small. I mean, sometimes if it's an area where there's a little bit of tension and it tends to be like gaping a little bit, I might. But for the most part, you don't have to. These incisions are very small. And it's very different than lipo incisions. Lipo incisions, they start out this small, but sometimes they stretch a little bit. And so then you want to put a stitch in, but these don't stretch out. You're not vigorously, going back and forth through the hole. You're not causing like friction injury. Another nice thing about this technology is you don't get the hot egress of fluid like you do with some of these other bulk heating devices. Because I've used them all. And the problem with some of the other ones is I don't know if it's gas or fluid, whatever that comes out of the hole can burn the skin. You get a little hypertrophic scar. So you think it's such a tiny little thing, you do it anywhere, but then you get a hypertrophic scar somewhere. That's not great. So I've never seen that happen with this. And you have to be careful not to come out, accidentally pull out and burn, because you can burn the skin if you do that. That's why this is designed, it's got these little rings on it. So you can tell it's like, oh, you're getting close, or you're really close, stop, right? So that was a really nice design to have those little rings. That was yours, huh? Yeah, good for you. So another thing to consider is your hole, normally when the button's up, the hole's facing upwards and downwards, which you can have treating that way. And theoretically, it treats everything anyway because it's 360. But if you wanted to somehow be a little bit more direct towards fibrous uptake, you can turn it. And so then your holes are sideways. So I mean, there may be some benefit here because maybe you're actually treating a little bit posterior dermis. But I don't know if it makes a difference in terms of the outcome. I think either I've done it both ways. Everyone seems to get an outcome. But if there is a difference, it's too subtle to notice just in the clinical setting. So one area to be careful of is both sides of the trachea, because that is one area you will likely crosshatch when you come from the front. So just make sure that you're not moving so fast that you're treating that area while it's still hot. And because if you're going to get an injury, it'll be there. The first pass in an area, there's always a little bit of resistance. Second pass tends to be easier. And after you've done a couple, it tends to move very easily. All right, there you go. That was a fault. So I'm glad you guys heard that. So that basically means that the gas was stopped somehow, it didn't flow. So that can be caused by me pressing it, like if I do this and press it and it doesn't come out, or it's starting to get clogged. So clean it. And if that happens, clean it. But you should really clean it even more often. And I'm guilty, I'm sure everyone else is. You just forget. You're like you're doing your procedure, and then you realize you've been doing it for 15 minutes, you haven't cleaned it. That's a recipe for clogging the tip. So everyone's going to do it, but it's best if you clean your tip probably every few minutes. We're actually getting pretty close to the end here.
How long would you normally schedule for this case?
I mean, probably an hour and a half, just because there's like setup time and injection and, you know, futz around and stuff like that. But it depends. If you get, I mean, if you have like a clinic where you have like these types of patients lined up, I guarantee you can do these done very, very fast. Just a matter of getting efficient with all those little steps. The treatment itself is quick.
You obviously have a surgical suite, but you could do this in an office procedure room.
Oh, absolutely. The reason we do it here is just everything's more roomy. You know, we have a place for people to stand and watch. My office, the rooms are much smaller, so. So now I'm gonna do a little bit in the middle. And again, I just treated this side, so I'm going to start with this side. Just give this a second to cool down. And I don't mind cross-hatching a little bit as long as it's been a minute since I treated. Another thing to keep in mind is after you've treated the neck, spend just a moment to put a little energy right just in that little space near the hole. Now, you have to be careful there, because if you go over that area over and over, you over-treat it. But usually you don't go back that far. The reason why I think it's important, especially in this case, so if you don't treat it, is sometimes this is a teeny laxity right there, because everything else is tight. And good indication that you're actually getting some benefit when you miss a spot. Stay superficial. With the other devices, they tell you to be careful of the thyroid, because they don't want you to heat it. But this, because this is so superficial in terms of the tissues it's treating, you're not getting down to the thyroid. I mean, this was originally used for burning endometriosis off the bowel. I mean, if you can do that, you're not going to damage any deeper structures.
You've done so many of these, so you probably no longer do this, but do you ever demonstrate kind of what you're seeing physically in the in the contraction from side to side? Or does that help you decide how many passes you're doing, or do you?
I don't even do that. I mean, you can, but you're going to get the same amount of, you're going to get a certain amount of contraction just based on the protocol you use. And if you put more energy, you're not necessarily going to get more contraction, at least not in the neck. So yeah, and so there's almost no point in doing that other than just for fun, for your own edification, or if you're demonstrating it. Probably should have demonstrated it today. It would have been fun, but I forgot. So, but you're going to get the result regardless.
Does patient need lymphatic massage after?
Not necessarily, but I'm sure it doesn't hurt. I mean, it's just like liposuction. Do you have to do lymphatic massage? No. Does it help them a little bit with edema? Maybe. So I personally like cryotherapy better. I think cryotherapy I think reduces post lipo edema more than lymphatic massage. I'm not against lymphatic massage. I just think cryo tends to work better for most patients, and it's easier. I mean, it's quick and it's easy, and most patients like it. Some patients hate it. So some just can't handle it. But all those types of things I think help recovery a little bit. I think red light therapy helps a little bit. Effective reduction, I think, certainly helps. Okay, so you can see she's still kind of puffed up. Her eyes aren't bad. This one's a little puffy. Close your eye for a second.
Were you uncomfortable at all?
She's a good patient. As we all know, we have patients that have different types of tolerances. Let me borrow that. Just do this side.
Dr. Rogers, would you mind doing a little video for Instagram?
Sure.
Ready, set, go.
We just finished our patient today for a Renuvion training, and we treated her face and neck. And this we basically did the standard protocol for Renuvion, so she should have a nice result. She is just showing us some early signs of aging where you have a little bit of laxity. But she wasn't the kind of person that had some people have really bad necks, and Renuvion may not be the best person for that. But when you have a little bit of laxity, it's excellent, excellent.
Thank you.
I mean, even patients with a horrible necks, honestly, they do get benefit. And so if they don't want to do a facelift or a neck lift, this is a very good alternative for those patients. So again, I'm sure people out there are doing treatments on 70-plus-year-old patients. I don't like to do it. I find that they do have a tendency to not tighten as much, and they may lose a little more fat, so the outcomes aren't as good as I want them to be. So I tend to, in those patients, I just recommend facelifts. Okay, we're done. That's it. So
We don't have any further questions, so we want to thank you so much for a wonderful event.
good.
Great success. Thank you to the patient as well. All right, and thank you all of you that attended. We'll see you next time.
All right, bye everyone.